Hello, I'm Dr. Mark Levy, and I'm a general practitioner in London, and I was the clinical lead for the National Review of Asthma Deaths, which we published in the United Kingdom in 2014. And it's now 10 years since we published the National Review of Asthma Deaths, also called the NRAD. And I'm going to just share some thoughts about where we are today in the United Kingdom with regard to asthma. Asthma is a chronic disease which affects the lungs, and what happens is the disease causes inflammation, which causes irritability of the air passages, which result in wheezing, coughing, shortness of breath, and chest tightness. Now, these symptoms vary over time and in intensity, and you also get variable airflow limitation. So this disease causes symptoms which come and go. So you might be 100% fit on one day and ill on the next. And the other problem with asthma is that it flares up in the form of attacks, which are a result of the inflammation, which is increased. And this results in obstruction of the air passages. So you get tightening or bronchospasm of the air passages. You also get swelling of the walls of the air passages. And you also get a collection of mucus or phlegm inside those air passages. And so the problem here, of course, is that this can reduce the amount of oxygen that you breathe in, which keeps us alive. And an asthma attack really means that something has seriously gone wrong with the chronic treatment of this disease. And I wanted to emphasize that it's a chronic disease which flares up from time to time with acute attacks. And we need to make sure that we treat the chronic aspect of asthma as well as the acute attacks. Now, the treatment of asthma involves chronic, ongoing treatment, and this is mainly with anti-inflammatory inhaled corticosteroids, supplemented by education for people with asthma, so you know how to recognize attacks and what to do when that happens. Attacks are treated first of all, by assessing the severity of the attack to see how bad it is and what needs to happen immediately. And the drugs that are used are bronchodilators, which open up the air passages, oral corticosteroids to deal with the underlying inflammation caused by asthma, and oxygen to make sure that you get enough oxygen going into your body, despite the fact that your air passages are tightened. And then after treating the attack, what should happen is a detailed assessment to decide whether you're better or not, whether you can be sent home or whether you need to be admitted to hospital. And after the treatment of the acute attack, a post-attack review should be done. And I'll talk a bit more about the post-attack review, but essentially that's to find out two things: whether the attack is over, and also, if it is over, what actually caused the attack, and how can future attacks be prevented. Now, I mentioned that we use bronchodilators for treating acute asthma attacks. Now, these bronchodilators are called SABAs, short-acting beta-agonist bronchodilators. In the UK, the drug is called salbutamol. In other countries, it might be called albuterol. And this drug is really an emergency drug used to relieve spasm of the air passages. It does not work for the underlying inflammation of asthma, and therefore should not be used as regular treatment without an inhaled corticosteroid. And the problem with regular treatment is that it stops the air passages from responding to the drug, so even though you're taking it regularly, it doesn't actually open up the air passages and relieve the spasm. It can cause rebound hyperresponsiveness, which means that you get rebound spasm of the air passages, which can be life-threatening. It could kill you. And you'll also get decreased response of that drug if you carry on using it repeatedly. Now, the other factor that regular use of these reliever drugs can cause is increased allergic response. So it can actually make the irritability of the air passages worse. And if you get 3 or more prescriptions for short-acting beta-agonists, these are usually the blue inhalers, a year, your chance of being admitted to hospital with an attack increases almost twice. So it's not safe to only use the blue inhalers for treatment of asthma. And if you're prescribed more than 12 in a year, that increases the risk of dying from asthma. Now, in November 2023, in the United Kingdom, a coroner released a Regulation 28 statement, which was published, so this is in the public domain, and a Regulation 28 statement is a statement following an inquest which found that a death was potentially preventable. Now, this little boy had a severe life-threatening attack on the 27th of October 2020, so bad that his mother had to resuscitate him until the paramedics arrived. He was taken to a hospital, treated there, and then discharged within 4 hours without being referred to a specialist pediatrician with asthma expertise. And then what happened is that the general practice treated 4 subsequent attacks in the next 7 months with prescriptions of oral corticosteroids without referring him to hospital, without referring him to a pediatrician with specialist interest in asthma. And then after the 4th attack, the practice delegated a nurse to do a post-attack asthma review. And unfortunately for this child, neither the nurse or the doctors in the practice recognized that this boy's life was at risk. He'd had a life-threatening attack, he'd had 4 subsequent attacks, and according to the coroner's report, he was not prescribed sufficient inhaled corticosteroids to prevent attacks, and also according to the coroner, he was prescribed excess short-acting beta-agonist bronchodilators, those are blue inhalers. And so the risk to this boy's life was obvious, and nobody in the practice actually did anything to prevent his death. And we did publish an editorial in the British Journal of General Practice in February this year, which I would recommend that you have a read of. Now, sadly, this story of William Gray, this little boy who died, is not really unusual. We've known about the factors that cause asthma deaths for nearly 60 years in the United Kingdom. And 10 years ago, we published the National Review of Asthma Deaths, which was published by the Royal College of Physicians. Now, this was a confidential inquiry which was commissioned by the Healthcare Quality Improvement Partnership on behalf of all 4 health authorities in the United Kingdom. And the work was delivered by the Royal College of Physicians. The aim of the NRAD was to understand the circumstances surrounding asthma deaths in the UK in order to identify avoidable deaths and to make recommendations to improve asthma care and also self-management of asthma. The panels were tasked with 3 questions, really. When they looked through the records of the people that we reviewed, they wanted to know, they were asked to find out, did the person have asthma? Did asthma cause the death? And were there any preventable factors? Now, out of the 900 cases that we considered, we only had sufficient data for 276 who we thought probably died from asthma. And the panels concluded that 2/3 of those people, 195 of those people, died from asthma. And they made 1,000 different recommendations. Now, what they also found was that there were major, potentially avoidable factors in at least one of 67% of those people who died. So there was at least one preventable factor in 67% of those people who died. One of the key findings was that we were prescribing excess short-acting beta-agonists, which I've told you already do not work against the underlying inflammation, the underlying cause of asthma. We prescribed insufficient inhaled corticosteroids, which would have protected people against attacks. 46% of those people who died were being cared for by nurses without asthma training that would have given them the competence to deal with asthma. And I'll talk a bit more about delegation a bit later. The panels also found avoidable factors related to follow-up after attacks. 10% of those people who died in the NRAD had been treated and discharged from hospital within 28 days. So the hospital treatment for the attacks was not sufficient. Although they might have thought the person was well when they sent them home, they weren't followed up, so they didn't have a post-attack review. In most cases, they didn't have a post-attack review, and they were discharged into the community in the hope that they would see somebody with asthma expertise. Now, at least 21%, 1 in 5 of those people who died, had attended emergency departments at least once in the year before they died. And so there were risk factors, and the main risk factor here is an asthma attack, which is a predictive factor of a future asthma attack. These risk factors were not really recognized. The acute disease was treated, but not the chronic underlying disease. And so we recommended that everyone should have a post-attack review after being treated for an asthma attack. And everyone who had 2 or more attacks in the previous year should be referred to an asthma specialist, first to assess whether they have asthma or not, and also to determine whether they're on the correct treatment or not. And that didn't happen in the majority of the cases who died. The panels also concluded that there were problems related to lack of patient education. Now, 45% of people who died without calling for or getting medical help. Not surprising, because over 3/4 of those who died had no evidence in their medical records that they'd been provided with a self-management education plan, which would have helped them recognize attacks, know what to do, and how to get help. The NRAD made 19 key recommendations, and only one of those has been implemented nationally in the United Kingdom after 10 years. And this is a national ongoing audit of asthma being conducted by the Royal College of Physicians. Now, I'll remind you that asthma management involves chronic ongoing treatment because this is a chronic ongoing disease. It's there all the time. And it also involves treatment of acute attacks, which I've discussed earlier. Now, in the United Kingdom, the problem is that we're focused very much on acute attacks. We treat the attacks usually very well, but we don't go back and try and assess and find out what went wrong and treat the chronic underlying disease. And I think what we could remember from this talk is really that we need to attack the asthma risks in order to prevent asthma attacks, because the next one might be fatal. Now, since the NRAD, I've been expert witness in 5 coroners' inquests, and the coroners issued Regulation 28 statements in 4 of those. And the lessons and messages from all of those coroners' Regulation 28 statements were very similar to the messages and the recommendations that we made in the NRAD, and similar to a number of the recommendations made in the past by studies in the United Kingdom, including the one in 1983 on 90 asthma deaths in the British Midlands, which was published by the then British Thoracic Association, which is now the British Thoracic Society. Now, what happens after these Regulation 28 statements is that there's usually short-term publicity. There's a lot of noise in the press, doesn't last very long, without national implementation of the recommendations made by the coroners. So we're not learning from these deaths. And there are very few exceptions where there's national action. And the one that I mentioned was on the tragic death of Ella Kissy Deborah, who was found by the coroner to have died from an asthma attack which was caused by air pollution. And this did result in national action by the UK government. Now, to come back to William Gray's story and the fact that his post-attack review after the 4th attack treated in the practice in 2021 was conducted by a nurse in the practice. And sadly, she didn't take action to alert the doctor to make sure that this boy was referred immediately for assessment and treatment by a specialist, because there were obvious signs that his life was at risk. And to reiterate, he'd had a life-threatening attack 7 months previously. He'd had 4 subsequent attacks treated in the practice in the next 7 months. He'd been prescribed excess short-acting reliever blue inhalers and insufficient preventer inhalers. Now, that should have been enough to alert the nurse to call for help. And sadly, what's happening in the United Kingdom at the moment, in my view, one of the greatest risks for people with asthma is that we're inappropriately delegating asthma care to people who are not sufficiently trained in asthma. And this particularly relates to physician assistants, nurse assistants, healthcare assistants, as well as other individuals, clinicians. And this is dangerous. And the danger is both for patients, but also for the doctors who are delegating the care, because you're putting your career at risk. Our General Medical Council is quite clear. If you delegate care to someone else, you need to be sure that that person is adequately trained, has the competence to do the task, and that you are prepared to supervise the care given by that person. Now, fortuitously, on World Asthma Day, the day before I did this presentation at the House of Commons, our GINA organization, the International Strategy Organization, published our new World Asthma Day theme, Asthma Education Empowers. And the idea is that if we can empower patients through properly educating healthcare professionals who provide education for patients with asthma, as well as providing education for policymakers and pharmaceutical industry, we can improve asthma care for people. So for the year 2024, this is the GINA theme, the Global Initiative of Asthma theme for this year. Let's focus on empowering people with asthma education. I know that I've been focused in this talk about asthma deaths, but I want you to remember that it's not only about asthma deaths, it's also about asthma attacks. Because if we can prevent asthma attacks, we can prevent hospitalizations and we can prevent asthma deaths. Now, I was phoned 2 months ago by the mother of a 9-year-old girl who I treated in general practice 5 years ago. I'd prescribed a low dose inhaled corticosteroid for her. Now, last September, 6 months ago, this little girl had a severe asthma attack, so severe that the paramedics insisted on taking her to hospital. And after waiting in the hospital casualty department, the ED department, for 10 hours, she was discharged home by a doctor without being seen or without referring her to a pediatrician with expertise in asthma. And then a month later, they saw the asthma nurse in the practice. And the nurse advised Mom to stop all asthma medication because the girl was okay when she saw her. Now, fortunately, the mother didn't stop the preventer medication, although it was still at a very low dose that I'd prescribed 5 years previously. And this little girl had another attack. This was in March 2024. It was a severe, life-threatening attack. Mom had to give the child 22 puffs of her short-acting reliever drug while waiting for the emergency service to phone her back. This is the 111 service that she phoned for help. And eventually she was told to take the child to casualty, which she did. And again, after a 2.5-hour wait in the casualty department, she was sent home without a referral to a specialist or without any follow-up being arranged. The mum was clearly very distressed and very worried about her daughter, and that's why she phoned me. And with agreement of the mother, and after discussion with a specialist in pediatric asthma, I managed to ask the practice, who agreed, to refer the child to the specialist for a review. And the specialist saw the child urgently. And he did tell me that he was quite distressed. He had his head in his hands after seeing the girl, after hearing the story. So we need to stop this kind of thing happening, really, and take asthma much more seriously and stop treating it as if it's an acute disease. Now, 10 years on from the National Review of Asthma Deaths, what has changed? In the United Kingdom, we now have the 4th highest number of asthma deaths per 100,000 in 38 OECD countries. Asthma deaths have increased in only 7 of the 38 OECD countries, including the United Kingdom. UK pediatric asthma mortality rates are the highest in Western Europe. And there's been no significant reduction in hospital admissions in the UK, which is now one of the 3 countries that has the lowest reduction in hospital admissions. That's 1% reduction in hospital admissions, compared to countries like Sweden, who've reduced them by 60%. And 38% of people with asthma in the United Kingdom are being overtreated with short-acting beta agonists. Those are the blue inhalers, which I've told you can actually lead to death. If used regularly without an inhaled corticosteroid, or even with an inhaled corticosteroid, if used regularly, they can lead to the death of a person. So we need to change our prescriptions. Now, I've spoken about post-asthma attack reviews a couple of times, and in my view, this is probably one of the most important take-home messages. If someone's had an asthma attack, it means that something serious has gone wrong. And we need to treat the attack clearly, and after the attack, we need to review the patient, first of all, to determine whether the attack is over. If it's not over, we need to do something. We need to either readmit the patient to hospital or change the treatment, maybe prescribe more oral corticosteroids, or change the inhaled corticosteroids that the patient's been taken. And secondly, the second reason for doing a post-attack review is to find out why the person had the attack. So we need to do a quality assured review by somebody trained to do so, who can identify and deal with modifiable risk factors, and then optimize care and provide a new or revised personal asthma action plan and arrange follow-up. The GINA asthma management cycle summarizes everything that we should do when reviewing a person with asthma, either following an attack or as a routine review. And it starts with an assessment, and that will include confirmation of the diagnosis, identification of symptom control, risk factors, comorbid conditions, checking inhaler technique, and identifying and dealing with patient preferences and goals. And then the treatment will be adjusted in accordance with what's found in the assessment. And this will include non-pharmacological strategies. It'll also include education of the patient. And then the person will be reviewed at an appropriate time thereafter. Now, the GINA strategy is published every year based on the evidence published in the previous 18 months. And I would recommend that you go to www.genasthma.org and download the strategy document for your own use. The new version was published on World Asthma Day in May 2024. So I'm going to leave you with 4 of my own ideas for national implementation to improve UK asthma care, and these might apply in other countries as well. And this might need long-term incentives because general practitioners are certainly under extreme stress at the moment, and without adequate resources it's quite difficult to be able to provide good quality care. Now, I will say that I do stress that this does need to be national implementation, because we can't rely on local organizations to prioritize asthma. They're told centrally by government and health authorities what to focus on, and that's what the local payers will focus on, and not necessarily asthma. At the moment, the local organizations are called integrated care boards, and the name of these local payer organizations changes every few years. I've been a GP for many years, and they're currently called integrated care boards, but you'll know what I mean if you're in the UK. So firstly, I think we need to improve quality of patient education. And this goes right to the heart of what I was saying about delegation. We need to make sure that adequate resources are available for training and supervision of those people delegated to provide asthma education. It might be doctors, it might also be these assistants who are now being directed to deliver this care. Secondly, in my view, like we do for cardiopulmonary resuscitation, where doctors have to do an annual training course, which might last a couple of hours, on resuscitation. Asthma attacks are very common, and I think we need to mandate appropriate asthma competency-based training for all frontline staff, not just a lead in a primary care practice or in a primary care organisation or a payer organisation, because that lead might not be available on the day that somebody comes in with an asthma attack. And this training should include management of acute asthma attacks, to include all the aspects that I've spoken about, including proper assessment before, during and after treatment, delivery of drug care, and also focused on post-attack reviews, identification of modifiable risk factors, and optimizing care as a result. If we can do that, we will prevent attacks and we will reduce workload. And third, we need to stop treating asthma as if it's an acute disease, and we need to stop treating it with reliever drugs alone. Those are the blue salbutamol or albuterol inhalers. They should not be only used for treating asthma, and we should be prescribing inhaled corticosteroid preventer inhalers for everyone with asthma, ideally in the form of a 2-in-1 inhaler with an inhaled corticosteroid with formoterol, which is a quick-acting, long-acting bronchodilator. And the fourth suggestion is that we should classify every single asthma attack as a significant event and a signal that chronic asthma treatment is just not working and that something has to be done. We can't just treat the acute attack and send somebody home, because they're going to have another one. Many people come back within a very short time period to a doctor or to a hospital with a new asthma attack. And my idea is a 7-step plan, which I've published on my website. That's bigcatdoc.com. And the 7-step plan is aimed at primary care, but there's no reason why it couldn't be done in emergency departments or even in inpatient care departments. And it starts with the agreement to do a monthly meeting to discuss asthma attacks. So we need to code asthma attacks as such. So the person in charge of coding hospital correspondence or doctors treating patients need to code the attacks as such. Don't code it as seen with wheeze or cough or seen in hospital. Code the attack as an acute asthma attack. And that will enable somebody in the practice who's delegated to do so to allocate that patient to a person in the practice with clinical experience to extract data from the records related to modifiable risk factors. And I've provided a pro forma on my website based on a study we did, which helped to reduce admissions by 16%. And then those patients are discussed at a practice meeting once a month. The modifiable risk factors are identified, and there's an agreement to optimize care for the person who had the attack, or refer the person who had the attack if necessary to a specialist. There's also an agreement to identify any system changes that are needed. For example, to take short-acting beta agonists off repeat prescribing, so that if somebody requests a short-acting beta agonist, they're automatically called in for a review. Because, as I said, that drug's an emergency drug and they need to be seen. Tasks need to be assigned so that these are dealt with before. That's the dealing with the individual patient's optimization, and also changing the systems within the practice or the care centre before the next meeting next month. Now, in primary care, if you start with children, most practices in the UK will have 2 or 3 children having asthma attacks in a month. If you're having more than that, then you've got a problem and you need to deal with it very urgently. But it shouldn't involve too much work. And what this will do is it'll reduce your workload. It will reduce asthma attacks and preventable deaths. And it will also help to protect the environment, because we will reduce the number of blue reliever inhalers that are being dispensed in the United Kingdom, and I imagine worldwide, for asthma. Thank you very much for your attention. Please do share this talk if you found it useful, and follow me on my podcast and on YouTube.